Absolutely. So just going a bit more upstream, what is the problem that we have? So there's about 850 million people worldwide that suffer from chronic kidney disease, and they are affected or by what we call the cardiorenal syndrome, the CRS. And RAS inhibitors, which stand for renin-angiotensin-aldosterone system inhibitors, are the cornerstone for treatment. And they're not just organ saving, but they're life saving as well. And they are a part of all the guidelines. One of the key challenges of implementing those guidelines with RAASi therapy is hyperkalemia. And that actually has led to a lot of discontinuations, down titration of this life and organ saving drugs. So ZORA, which is a part of the crystallized evidence program, is looking at hyperkalemia, the current management, and how hyperkalemia impacts the implementation of guideline-directed medical therapy. So that's the ZORA studies. And there are multiple studies, and I'm one of the key investigators of those studies. And the way it's a real-world evidence, what we call RWE, the real-world evidence studies. And the data is collected from registries, from claims, and hospital medical records. So RAASi therapy, and just going over, what impact it has, what organs, it's a kidneys, it's a heart, also for blood pressure. And when RAASi therapies are discontinued or down titrated, it can lead to a multiple, impact down the line, but also hospitalizations that can happen. And that's we have seen in multiple studies, but also the mortality, the progression to end-stage kidney disease. And at ASN last year, we presented the data in which discontinuation of RAASi therapy led to a 76% increase in ESKD, end-stage kidney disease, and down titration led to 60%. So these are all things that impact the quality of life. It also impacts the quantity of life. And equally important is the finances. This really drives up the cost of care that we're providing to these patients. Right, so that's a very good question. Discontinuation of medications like RAASis, and some patient gets hyperkalemic, severe hyperkalemia. I think it's the knee-jerk reaction, and in most of the situations, the right reaction to down titrate or hold the medication till we have resolved the hyperkalemia. The problem comes reinitiating the medication, and there is what I call therapeutic inertia. See, if discontinuing the medication would be causing symptoms to the patient like headache and dental pain and chest pain, they will go and seek out care. But since most of these conditions are asymptomatic, it's really, it's like I said, once again, the therapeutic inertia. Now, you mentioned the KDIGO guidelines, which I would say the KDIGO 2024. And when you look at the management of hyperkalemia, it has gone a paradigm shift with the new novel binders that have the tolerability and acceptance as good as placebos. It's changed the way the hyperkalemia can be managed. The problem is that once again, there's a therapeutic inertia, and we are not leveraging the use of these binders appropriately to reinstate. And also you have to keep in mind, it's not just that these patients should be on RAASi therapy. They should be what we call on the optimum, which is a maximum tolerated RAASi therapy. And that also is very important because number one is to get them back on, but also titrate that up. And there's a lot of therapeutic inertia over there as well. And the other thing that I want to point out, I'm an investigator on multiple ongoing studies, whether it be glomerulonephritis studies, whether it be CVRM studies, they have to be on a baseline, what we call foundation therapy. The key word is foundation. They have to be on the foundation therapy of RAASi inhibitors and the optimal dose. And once again, the optimal dose is the maximum tolerated dose. So therapeutic inertia is something, behavioral changes are important. Now, you said, why are we lagging behind that and what can we do, right, to overcome this? So one of the things that is getting a term that's, or practice is being commonplace, is called value-based care. So what does value-based care mean, the VBC? Value-based care means is that you treat the patients and they are on the guideline-directed therapies. They are on what we call the organ and life-preserving therapies. And RAASi therapy is one of them. And let's see how this pans out. But we will need to do a lot. And the other thing is, we don't, the results, depending upon what stage you're in, it might happen early or it might take longer. But at UCLA, we are really looking into that in my own healthcare system, in which we're looking at RAASi therapy. We're looking at SGLT2 inhibitors. We're also looking at MRAs, melanocorticoid receptor antagonists. No, that's a great question again. And one of the things that I want to point out, there were 3 studies, that was at the ERAS this year. And there were other studies that were presented prior to this in 2023. And this is an ongoing, we're looking at the data, we're looking at how things are coming in. But for these studies, I do want to mention they had patients from the US and Japan. And if you think about this, these are advanced countries. These are not, these are where patients are supposed to be getting the best care. And if you look at the 3 studies, number 1 study you mentioned, if the patients were on continuous therapy, right? And they looked at data on LOKELMA that was being looked at. Providing these patients with a continuous therapy of LOKELMA led to higher number of patients staying on RAASi therapy, 70 to 80% if you look at the numbers. And in the other one, the patients who stayed for more than 1 month on therapy had a higher chance of staying on therapy as well. And the last one you mentioned is hospitalizations. In patients who stayed on therapy had a lower incidence of hospitalizations. And the 2 other studies that were presented last year, once again, keep in mind the US and Japan. In one, if the RAASi therapy was discontinued, there was a higher chance of, as I mentioned already, I forgot, it was 73 or 76% ending up with ESKD if you stopped it, and 60% if you down titrated that. That's the other important point that I want to mention, that even if they were on the therapy, but they were not at the optimal dose, there was still significant chances of them advancing to ESKD. Now, the other point was reinitiating patients with CKD plus minus heart failure. They had a hyperkalemic episode. They were stopped. Reinitiating therapy was quite low, to 10 to 15% if you look at the number. So why is this important? Once again, if you look at the condition they were treating, they tend to be silent, and the onus is on the providers to reinitiate therapy and titrate that up. And the ZORA is a wealth of information. We have had multiple publications, presentations coming out of it, and a lot more is going to be. And I think it's going to change the way hyperkalemia is managed. This is something that I think is I'm also a pharmacologist besides being a nephrologist. And I always say drugs and medication should not be a substitute for lifestyle changes, right? If somebody is on a high avocado diet when they should not be on that, which is rich in potassium, then I think that needs to be addressed, right? But the judicious use of medication is very critical. And I think this is where, once again, we have to push the envelope in patients who actually are getting hyperkalemic. We have options available for drugs like LOKELMA that are almost as good as, I won't say placebo, but very well tolerated overall and very minimal side effects and adverse events that can be managed. So I think for our healthcare providers, I really want, now, whenever they see a patient who should be on a RAASi therapy, the question they should ask is, number 1, are they on? Number 2, are they on the maximum dose? And if the answer to either one of them is no, the question they need to ask is why? What can be done? So I think that's where value-based care comes in, and there is no price on life, right?